My name is Hoang Nguyen, one of the second-year medicine residents. I'll be doing this talk on the proposed myth of thiamine, giving thiamine before glucose to prevent Wernicke's encephalopathy. I have this picture here of a book written by the neurologist Oliver Sacks. It's called The Man Who Mistook His Wife for a Hat. It's a collection of stories in his experiences as a neurologist of several of his patients, and one of the stories is about a patient with Korsakoff Syndrome. As I'll talk about is a progression of Wernicke's encephalopathy. Just a brief overview of Wernicke's encephalopathy. This is a clinical triad of ophthalmoplegia, ataxia, and confusion. The definition has expanded to include ocular dysfunction, not necessarily ophthalmoplegia, ocular dysfunction, including nystagmus, sixth nerve palsy, ptosis, retinal hemorrhages, papilledema. This has been thought to be caused by a thiamine deficiency. Usually in the typical diet, we have enough thiamine in our diet to maintain our body stores. However, if you are to go without any thiamine completely, the stores are probably only sufficient for about 2 or 3 weeks. Some predisposing factors: chronic alcoholics, people on a polished rice diet, malnutrition, recurrent vomiting. Sometimes you'll see this in patients with hyperemesis, GI surgery, HIV, AIDS, malignancy, systemic diseases, and chronic TPN. Patients that do survive the syndrome of Wernicke's encephalopathy, about 80% of them will develop Korsakoff Syndrome, which is antegrade amnesia with short-term memory loss, and that's usually compensated with confabulation. Usually these patients will have their long-term memory and cognitive skills preserved. The classic triad that I mentioned earlier is only seen in 16% of patients. There has been a criteria for the diagnosis of Wernicke's encephalopathy. Usually you would want 2 of the 4 that are described here, either nutritional deficiency, altered mental status, ocular motor abnormalities, or cerebellar dysfunction. Usually it's a clinical diagnosis, and so if you have 2 of those 4, the sensitivity is quite high if there's no evidence of hepatic encephalopathy. Other syndromes that can manifest from thiamine deficiency include cardiac beriberi, also known as wet beriberi, high output cardiomyopathy, dry beriberi, which manifests itself as peripheral neuropathy, and even as of late, there's been some evidence of GI beriberi as well. MRI imaging isn't necessary for diagnosis. Like I mentioned, it's a clinical diagnosis, but if you were to get imaging, the sensitivity is not that high, but it's quite specific, up in the 90% range. You'll see these lesions in the midline here, usually around the third ventricle, the periaqueductal area, also the mammillary bodies. Mammillary bodies are actually quite specific for the syndrome. A little bit more about thiamine. So vitamin B1, in its biologic form, it's a coenzyme for several biochemical pathways. Without thiamine, glucose is metabolized through lesser efficient pathways, and without thiamine, the enzymes aren't able to function, which produces toxic metabolites, including lactic acid. The acidosis accumulates in these periventricular structures, as seen in the MRI earlier. Thiamine is taken into the brain via an active transport process, and so patients that are thiamine deficient, you can correct that by maximizing the serum levels. The standard right now is to treat with 500 milligrams of IV thiamine 3 times a day. And by really loading up the serum levels, you're maximizing that concentration gradient to promote the transport to the brain. And oftentimes in these patients with Wernicke's encephalopathy, alcoholics, malnourished patients, oral absorption is really unreliable, and so you would have to treat with intravenous or IM thiamine. Here's a pretty complicated slide, but this takes us back to biochemistry. Several pathways that are affected with thiamine deficiency, including the pentose phosphate pathway, anaerobic metabolism, and also the Krebs cycle. And so as you can see, if you're missing thiamine, you will have an accumulation in products such as lactic acid and also the pentose phosphate pathway that can affect myelin sheath production. So the myth, what we've been taught in medical school is that thiamine, you should always give thiamine before glucose to prevent Wernicke's encephalopathy. Concern is that giving a big glucose load will completely deplete the existing limited thiamine stores. And in addition, giving the carbohydrate load will lead to a buildup of metabolites such as lactic acid. This myth has been shown, in a lot of our medical books, including Boards and Wards, First Aid, Master of the Boards. You can see that it all mentions that thiamine should be given prior to glucose. This is also described in Up to Date as well. So, going back, where does this myth come from? In reviewing the literature, it appears to be the myth seems to come from the theory and based on the biochemical pathways that you're just building up these metabolites without that are deficient with thiamine deficiency. So I was able to review the literature to see if there's been any evidence behind it. A lot of these studies have been traced back to case reports, the first of which was written in 1951. This was a study, basically an observation case series study of 9 patients. They had exhibited symptoms of Wernicke's encephalopathy. Most of them were chronic alcoholics. They didn't have any food intake in the weeks prior to the study. All of them were started on an IV solution of glucose with saline. No other nutrients were given, no vitamins, no minerals. They were able to assess symptoms of Wernicke's by measuring the power of the abduction of the eyes to assess the degree of the ophthalmoplegia. In 6 of the 9 patients, the paralysis worsened throughout their clinical course after the IV solution of glucose was given. When thiamine was given, usually around day 3 or day 4, those symptoms had improved. And I believe in most, if not all, of the patients, the symptoms did improve, subsequently. This is a nice diagram demonstrating their course. As you can see, this is one of the patients, patient number 2. The glucose was given on day 1, and thiamine wasn't given until day 3 or day 5. I'm sorry, and you can see that the external rectus paralysis did worsen from 3+ to 4+. And once thiamine was initiated, it had improved. And some of the other symptoms were a little bit slower to improve, including the ataxia and confusion. This study didn't actually look for glucose as a precipitant of Wernicke's encephalopathy. It was mainly looking at thiamine and other vitamins. The next study that I was able to find is this written in the New England Journal. It's a case report of the occurrence of acute Wernicke's encephalopathy during prolonged starvation. It's a 35-year-old male. He was admitted to the hospital for prolonged starvation, basically starving him for a month. After 30 days, they refed him with a glucose, just only glucose diet. After 5 days of that glucose diet, he had complained of some dizziness, and so they treated him with orange juice. 7 days after that, he complained of double vision, nystagmus, 6 nerve palsies, and confusion. And so after 12 days of the glucose diet and the orange juice, they had initiated thiamine supplements, and his symptoms had improved. So the first big study that actually tried to attribute glucose to precipitating Wernicke's encephalopathy is this case series written by Watson in 1981. Basically, again, for cases of Wernicke's encephalopathy in malnourished patients, they had been given a glucose load at different amounts and doses, and throughout their clinical course, their symptoms had worsened with all the clinical signs of Wernicke's encephalopathy. What should be noted in this study is that a lot of the patients initially had some symptoms of Wernicke's encephalopathy already, including ocular motor dysfunction, ataxia, and they were also all treated with thiamine. This is probably the biggest study that the myth has been traced back to. Here's another one. 41-year-old male doctor, didn't have any signs and symptoms of Wernicke's encephalopathy to start. He was given D5 with saline, and then the next day he was noted to have nystagmus, retinal hemorrhages, ocular motor dysfunction. Again, treated with IV thiamine, and then improvements in some of the signs. From this study, it was hypothesized that glucose was the final insult to a depleted thiamine body stores. So basically, all the studies that I've mentioned are case series where they were able to appreciate the clinical signs of Wernicke's encephalopathy. They were worsened throughout their clinical course. It's really unclear from the studies if it was the glucose that may have precipitated the symptoms, or if it was just the natural progression. It seems like a lot of the studies, the patients were already having mild symptoms that did worsen throughout their clinical course. And of all the studies also, the symptoms didn't really mask until, or they didn't really come on until 2 or 3 days after they were hospitalized. This is perhaps one of the better studies that I was able to find. It was a rat model. They were able to create a rat model of thiamine deficient rats and compare them to control rats. They loaded these rats with 10 grams per kilo of glucose, and they were able to observe clinical signs and symptoms, and also assess performance using a moving belt apparatus 2 hours after giving the glucose load. So in control rats, there was no differences in behaviors or motor function, or in rats that were fed a thiamine deficient diet for under 21 days. However, in rats that were thiamine deficient for 28 to 35 days, the glucose load did precipitate episodes of gross ataxia and also neurologic dysfunction on these ataxia and advanced science scores. Also on the moving belt, their performance also decreased. Should also be noted that a load of 10 grams per kilo is quite large, and if you're able to extrapolate that to human studies, that would, in an average human being, that's 700 grams of glucose. So really tough to say how this would interpret over to humans. So given that all the evidence has really been case series or animal studies, in 2012, Schabelman sought to look for more of the evidence behind this myth. And so after an extensive search, all they really found were 13 case reports in series, some of which I already talked about, also 4 animal studies, and then 2 expert opinions. Only one case actually did show perhaps some acute change in mental status after an acute load of glucose, but it wasn't really described well, the timeline and the dose of glucose that was given. All the other cases show change in mental status and progression of Wernicke's either after a large load of glucose or a longer time course, not necessarily an acute exacerbation of Wernicke's. This is probably not soon after the literature review. There was this study that actually tried to compare giving glucose with or without thiamine in the field. So it was basically a retrospective cohort of 242 patients. They had received glucose in the field for hypoglycemia. It wasn't clear if these were malnourished patients or if they were alcoholics or if they were at risk for Wernicke's encephalopathy. But they were given glucose in the field for hypoglycemia. Their primary outcomes, they weren't able to assess things like ocular motor dysfunction out in the field, so they use criteria like GCS, heart rate, vital signs, and so those were their primary and secondary outcomes. The number of patients in each group, a large amount of patients received thiamine, 205, so 85% of the cohort received thiamine prior to glucose, while 15% did not. So not an equal amount of patients in each group. So what they found was that there was no differences between the thiamine and no thiamine groups. However, a large amount of these patients refused transport to the hospital, so they weren't able to follow their mental status after this acute load of glucose and thiamine. However, they did note that none of the patients in the study returned to the ED or were 911 was called. And so where does that take us today? In clinical practice, it's actually found a bunch of EMS protocols in many states, actually, where if they encounter a hypoglycemic patient and there's some evidence of malnutrition or alcohol abuse, that these patients are required to receive IV or IM thiamine prior to giving glucose to prevent the development of Wernicke's encephalopathy. Here's one of those protocols. This is in Alabama in 2018. This is their hypoglycemia protocol, and at the bottom there you can see if there's evidence of malnutrition or alcohol abuse, they're supposed to give thiamine prior to dextrose or glucose or glucagon. And so in conclusion, the evidence for this proposed myth is not that great. It's mainly case reports and small animal studies. It appears that initial boluses does not appear to precipitate Wernicke's encephalopathy. However, prolonged dextrose may precipitate it if thiamine is not given. Patients with hypoglycemia, per some of the recommendations in some of the academies, the emergency doctors are recommending that you shouldn't withhold dextrose or D50 if patients are hypoglycemic. That's more seen as an emergent situation, and so you should try to restore normal glycemia by giving dextrose. And after you do restore normal glycemia, that's when you would want to start thiamine. So not necessarily holding the sugar prior to giving thiamine. My opinion, I can kind of see why the myth came to be by giving thiamine prior to glucose, but in an emergent situation with low sugars, I think giving dextrose is probably more important than giving thiamine. Some of the studies have also shown that thiamine doesn't really seem to kick in until hours after, and so giving thiamine prior to dextrose is not going to do anything either. So you really just want to treat the low sugar promptly. These are my references. And just the other week, I was back home in Hawaii. Some of you have seen pictures of my dog, and so I just wanted to share a picture of my dog, Bear, and a little joke. Well, it says, I think I have a thiamine deficiency. and the next picture shows Bear again saying it's very, very bad. No.
All right, so does anybody have any questions or comments about that? I think all of us were kind of taught that. I mean, I know I was taught that. You guys were, do you still teach that? I don't know whether, I haven't really, it hasn't come up recently that I can remember. Maybe I just forgot about it.
We clearly give thiamine.
Yeah, we give thiamine, but the timing of it, I think, is the issue. And you know,
not giving it is an issue.
and not giving it is an issue. But I think clearly, you know, probably it looks like it takes days really for the glucose to actually have that kind of effect, if it has an effect without the thiamine from
What
the
about
data.
that rat study? I mean, that was the only kind of controlled study. Everything else is
It
just
was,
reports.
and I'm sure the rats were falling off their treadmills and their wheels. But yeah, I mean, but also they didn't. It wasn't really a controlled study. I don't think they gave thiamine in that study, or did they?
I don't think so.
Yeah, so it doesn't really, one way or another, doesn't really say that you have to give the thiamine first. I think that's the big deal that everybody always used to say, you've got to give the thiamine first. And it's kind of like, you know, dexamethasone and meningitis. You got to give it before you give the antibiotics. I mean, that's what we're taught. I don't know what the data is for that. That's a different problem, but it's the same kind of thing. People are told, you know, don't treat the hypoglycemia until they get the thiamine, and probably the damage of the hypoglycemia is probably worse. Yeah, Daryl?
Do blood thiamine levels correlate with brain thiamine levels or activity? You know?
Well, you said there was that gradient of the blood-brain barrier. The higher
is a gradient.
the higher the level, the more that gets into the brain, I guess.
But I think,
I don't know.
you know, there is the test that you can run for blood thiamine levels. However, it takes days for that test to come back. So I think, you know, possibly there is some correlation there, given that it is a passive transport process, and so that would seem to make sense. And speaking of the rat study, those were large doses of glucose. I mean, 10 grams per kilo, that would be like 700 grams for, you know, the average person. There were some other studies too, imaging studies, very similar models, thiamine deficient, and they were able to demonstrate some increased lactic acid activity in the mammillary bodies not soon after giving glucose. And so how much glucose, again, I think those were large amounts of glucose.
All right, so I guess it's time to vote. Is it a myth thiamine must be given before glucose or it will precipitate Wernicke's encephalopathy? How many people feel that it's true you have to give thiamine before the glucose based on what's been said? How many people feel that it's plausible? How many think that this is busted? All right, you got yourself a busted.